Good morning. Everyone could look up from their phones, look alive, take a deep breath. It's all good. I want to thank you all for coming to our session, Navigating the Waters of Catheter Care, Showering, Safety, and Standards. Now I'm going to start right off as we're going to be asking you all a lot of questions because it's an interactive session, not necessarily 100% telling. We want to gather information from you. So one of the things, if you haven't done this already, is to download the NKF Meetings mobile app. I've been using it ever since I came here on Wednesday, but you could also use it to complete all the pre-tests, post-tests, and evaluations on site. So if you need those continuing education credits, you could have it done. Please try not to do hours during the session, but unless it's 100% good, that might work. I'm not supposed to say that, but I just did. Downloading the app will also allow you to interact with the session polling and Q&A. And scattered throughout our entire presentation is polling questions, and it will give us opportunity to ask other questions and have an open discussion with you all and among ourselves. And you'll see your answers up on the screen. So it's pretty cool. All of our presentation slides are available on the mobile app and the SCM portal. And we gave our permissions for you to see the slides. So please share them with your colleagues or review them when you get home or even here. Share your experiences on social media with hashtag NKF Clinicals. So post photos that you take. And anything else of all of us or anyone that you see, anything in New Orleans or at the conference here, so that it generates more interest. So we appreciate that. Do call your NKF your professional home. Myself, I'm reading this, sorry. One of the great things about being part of NKF and on the program committee is not only do I get to meet all of you, but I meet colleagues and like-minded nephrology individuals as I'm here, and I talk to people in the hallway, and I get revitalized and just very much interested in what's going on and seeing this. So I'd like to take a moment and introduce myself. I'm Alice Hellebrand. I am a program committee member as well as part of the panel here. I am one of the founding team members for Dialyze Direct and also a past president for national president for ANNA and a current board member for the Renal Healthcare Association. And with me is, I'll let you introduce yourself because this is an open kind of talk. Dr. Johanna, would you like to introduce yourself?
So hello, I'm Dr. Jonna Collins. I am a nephrologist in Canada. I am a current glomerulonephritis fellow as well at McMaster University. And I was invited to talk today as I have been involved in some research looking at the importance of showering for patients that have central venous catheters on dialysis. And for part of the talk today, I'm just going to go over some of the research that we've published in AJKD looking at that.
Loretta?
And I'm Loretta Ezel. Good morning. And I have typically been a director for clinical operations for acute, chronic, adult and pediatric dialysis. So I'm just on the panel to bring some experience.
And as I said, it's an open discussion, but we're going to start off with Johanna is going to go over some information. Dr. Collins, I should say that. I'm so used to now saying Johanna.
That's okay. You can call me Jonna.
And go over a slide deck about some information that she gathered from her workplace that's related to catheters and showering catheters. Thank you.
Thank you very much. Okay, I think I just want to touch on a little bit of what we were talking about right before we started in that, I'm from Canada and I've done all of my training in Canada, and both of you are American, and there's just such a vast difference in how we approach catheter care and catheter management that I think over the course of the talk, I hope that we can get into a little bit more. But we'll start with this for now, but I think it just highlights the importance of recognizing the differences across centers, across countries, and everywhere. So I'd love to hear a little bit more from everyone in the audience about how you guys do things too, with respect to your protocols at your centers. So we'll get into that in a little bit. There is no disclosures for this talk. Today we're going to be looking at institutional protocols regarding showering when patients have catheters that are on dialysis. We're going to look at the current recommendations. We're going to talk about the recommendations that we have at our own institutions. And we're going to try to, understand perhaps why there isn't consistent communication regarding how to shower with a catheter, or should you shower with a catheter across various centers, and how can we navigate perhaps providing more clear guidance regarding this topic. So a little bit of background first. So around 500,000 patients in the US were on dialysis as of March 31st of last year. And 90% of those patients on dialysis were on hemodialysis. So with that, many had central venous catheters. And 80% of patients initiated on dialysis in North America actually have a central venous catheter. And there's been an increased prevalence reported in the literature in using central venous catheters in hemodialysis over the last decade. I will just pause there for a second and talk about one thing that was quite different about what we talked about just today, is that I've learned that in the States, there is you guys are driven to remove the catheter at 90 days after its first insertion. Whereas in Canada, we don't have that hard cut goal. And a lot of our patients are actually on have central venous catheters for quite a while. And there's less of a drive from the government side of things, I guess, to have that change. So I do think that we're kind of coming from two different perspectives, which is quite interesting. But still, that being said, the proportion of patients who have central venous catheters across both, Canada and the States is still quite high. And why that matters is with the central venous line-related bacteremias. The question is does showering increase the risk of central venous line infections or bacteremias? We don't actually know the answer to that. There has not been a randomized control study that has looked at, one population of patients who shower, one population that doesn't, and actually answers that question. So it's all theoretical, essentially, that you think that, of course, showering would lead to an increased risk of infection, but we don't actually have that data. And to create a study that would be powered enough to assess for the statistical significance of a meaningful difference in something that's already so rare would be quite hard. So this is really a talk to start, thinking about what answers to what questions do we need to have in order to help provide some form of guidance moving forward. So with that, we just want to ask, for those of you out in the audience, what is your facility's protocol regarding showering with a central venous catheter?
Interesting.
Mm-hmm.
Okay. So looks like, majority of us here, would say that the facility does not allow showering. 33% allowing for showering, and then 1/4 not having clear recommendations regarding their catheter care regarding showering. And then just one more question as well. we're just interested in learning a little bit more about the role that you all have in your healthcare setting. Okay, wonderful. All right, so with that, I'm just going to transition to just telling a little bit more about the study that myself, Dr. Molnar, and the whole group here that have listed on the slide have published this study last year in the American Journal of Kidney Diseases, and this was a survey study. We took a survey from both healthcare providers and patients themselves, looking at their perspectives on showering with central venous catheters. And this was a study that we did to try to help inform a little bit more about this topic, to see what kind of information we might need in the future to help provide further guidance. So for our healthcare provider study, this information went out to three main societies: the Canadian Society of Nephrology, as well as the North American Australian Vascular Access Consortium, and the American Society of Diagnostic and Interventional Radiology. And we received a total of 304 responses from healthcare providers. Patients then received a completely different survey. These were handed out in the dialysis unit in Canada. We had two academic in-center hemodialysis units that we approached patients in, as long as they were over 18 years of age, had been on dialysis for more than 3 months, which I now realize is interesting given the 90-day mark for you guys to have the line removed. And those who spoke English. We had 89 responses in total for our patients. Just to talk a little bit further about the healthcare provider survey first. So in this study, about 68% of our respondents were nephrologists, and 14.8% were our registered nurses. Around 3/4 were from Canada. We had about 18% from the States. And a lot of the people answering this survey had been taking care of patients on dialysis for many years. So 62% of them having taken care of patients on dialysis for more than 10 years. And this is some of the responses that we had from our study. So when asked, what recommendations do you make to patients on dialysis regarding their catheters with bathing and showering? 28% said that they recommend against showering, and 16% actually recommended strongly against showering. So together, almost half of healthcare providers said that they did not want their patients to shower. And then when asked if they have a dialysis shower protocol, only 26% of respondents actually had a shower protocol in their facility. And then the other question I wanted to highlight for the healthcare provider survey was that if a standardized protocol was to be tested in a trial, what outcomes would be most important? This is a bit of a confusing graph, but essentially the most important thing for healthcare providers was that it was not going to change the risk of catheter-related bacteremias. The second one would be exit site infections, and then patient quality of life essentially came third. So then let's transition toward the patient surveys. So as I said, patients received these surveys in the dialysis unit. We gave them 2 surveys as well. So the first survey that we did was actually a validated short-form vascular access questionnaire, and that's listed here. This is using a Likert scale from 1 to 7, with 7 being how much they agree with the statement. So when asked if they're satisfied with their vascular access, most patients actually were, so that was actually a 7. But just to draw your attention here to this part, so for social functioning during the last 4 weeks, They answered, my access caused me problems when bathing and showering, and that was a 4 out of 7. And if you look at how they've answered the rest of the questions, they identified with this response more than the other responses quite significantly. And then moving forward from the vascular access questionnaire, we also asked them a bunch of questions very specific to the type of things that we were interested in. So we asked them, has a healthcare provider ever told you not to shower? 42% said that they had been told not to shower, which is pretty in keeping with what the healthcare provider survey said. But interestingly, also 13% couldn't recall what had ever been told to them as well. And then when asked, so what actual method do you use for personal hygiene? 53% still said that they were actually using, that they were showering as their primary method. So over half of our patients are still showering, regardless of the fact that many of them are recommended not to. The other ways that they went about their hygiene were reported as sponge bath or a full bath or multiple methods, maybe including showering. Interestingly, we also had a bit of a qualitative part of this question where we asked them, okay, so if you're showering, how do you actually go about doing this? And a lot of the responses were, my partner will help me tape a piece of plastic around my line, or I'll tape a towel around the line. I'll cover my whole upper body with a plastic bag. Various different things where they're MacGyvering, these very interesting ways of trying to protect their line as best as possible while allowing themselves to shower, which really highlights probably the importance of us trying to find a more standardized way, recognizing that this is likely something that patients are going to be doing anyways. We might not be able to answer the question of, is it going to increase their risk of infection or not? But perhaps there needs to be a bit of a middle ground where we can help facilitate something that's happening anyways in a more safe manner. And then I think this is a huge thing to consider, is that when asked, do you want to shower, 75% of the patients said, yes, I want to be able to shower. And I can only imagine the impact that this has on their well-being. And so when asked if the inability to shower does have a negative impact on their life, 51% of patients says that yes, it does affect me in a negative way, and it affects my quality of life. With that, we also asked, though, what are your priorities with respect to your catheter care? And quite similar to the healthcare provider answers, they actually do still say that prevention of infection is the most important for them, as well as preservation of their catheter access. So they are also, recognizing that this may be an infectious risk, and they definitely are putting that as a number one priority. But many of them also are recognizing that personal hygiene is also a priority for them. So further, showing us that we need to find some form of balance. And so finally with that, we asked them, would you be willing to participate in a shower protocol study? And at least 1/3 of them said that they would. So this kind of leads to the conversation that we'd like to have. I would love to learn a little bit more about, what type of protocol do you have, if at all, and perhaps what type of information you think we would need in order to implement these types of protocols. Because as I said at the beginning, doing a randomized controlled trial that's powered to find a statistical difference in, in bacterial infections in this population is likely not feasible, likely not ethical either. So how can we best move forward with addressing these concerns with the data and the rigor that we need, so that we feel as though we're doing this safely? So. And then just to conclude, there is widespread variations in practice with respect to showering in hemodialysis patients. Both healthcare providers and patients share the concern for the potential risk of infection.
But the inability to shower greatly affects patients' quality of life, and therefore this is a question that we need to address further in our practice moving forward. So with that, I will hand us back over to our panel.
Thank you. So it's interesting, just the differences that we find in Canada versus the United States, how you react or educate patients who have a catheter. I found that to be amazing. I thought whatever I do, whatever we do, it's consistent across all countries, and it's just evident that it's not. And so when we put this session together, we wanted it, again, not to be a telling session, but a gathering of information about what your thoughts are. Now, I've been in dialysis for decades, and it was always as if we penalized the patient if they showered. Yet, as a caregiver and as a nurse at 6 a.m. in the morning, I kind of knew which patient probably showered and which patient didn't, and which patient I really wish they had. And so I can't imagine living on dialysis and not being able to have good hygiene. And we thought about it as we were discussing this session. What about the AKI patient who is only supposed to be on dialysis for a very short period of time? And we want them to maximize their life and not have dialysis control, and we tell them you need to go to work in the morning, or you need to have your social life, or you're a mom and you're dropping your kid off at school or PTA or whatever you're doing, or going just to the supermarket, and you're not able to take a shower. And personally, I don't mind sharing, if I don't have a shower every day, I just feel different. It just doesn't feel right. And just because I had a catheter, I think that would be really a detriment and lead to me being somewhat depressed and very uncomfortable and unable to really look at the whole picture of what's going on. Information's being thrown at me. Don't eat this. Make sure you come to the dialysis treatment. Don't cut your treatment. Don't miss your treatment. You're not feeling well. Take all these medications. And guess what? You can't even take a shower. And then you're acclimating to how I can do that by putting a plastic bag on or and being afraid or coming in. And I will right away say that I am guilty of the fact of having patients come in and saying, it looks a little wet, or did you put that back on? I know you did. I know you took a shower, didn't I tell you not to? You're going to mess up with my rates, and I'm going to have to, present this at QAPI. And worse, the state surveyors are going to come in and say that we have a poor unit. And I've been, part of that type of discussion. And yet, the most important thing, or at least for me, and we were discussing it with the panel, is am I teaching the patient from the onset not to tell me the truth about what they're doing? And where I really want to bring in trust into that relationship. So our first polling question, so that we could start this conversation about what you all find in your unit. Now, we're not here to change protocol, change practice. We want to open up our minds to say what's really going on. So do you believe your patients shower with a CVC? Well, we kind of thought that, but not 100%. Because I kind of thought somebody would say, not my patient. Because we tend to, not my patient, we educate them. So you think your patients do shower. So tell me about that. Would someone like to give me some information? Like, why do you think that? And are you telling them no? So they're not listening to what you say? Because I thought most of my patients were. I thought all of them were coming in and saying, after at least by the second or third treatment, that they somehow figured out how to take a shower. I had a number of patients, I don't know where they got that Tegaderm from, but it wasn't one that I gave them, and they found their way, and now maybe with, mail order, they were actually changing that dressing on their own. And we thought we were really smart at that time, so we started signing it, with our name and the date, which they couldn't mimic. And so I'm like, well, really, where's that little tag that, we put on here so that we knew when it was changed last? And then they had no answer for us, and it was terrible. So Loretta, your thoughts?
I have one.
Sorry.
We have a question first.
Danny?
We've been teaching everything that with a patient that has had their catheter for a long time, that showers in all those things, talk to a patient that has one, says, well, I've been doing that for years. Anything I've told them, they forgot.
We had a good number of people respond that their patients do take a shower. In one of the places I worked, we actually bought the patients an attachment that they could hold to shower, like the separate piece that's not hanging above their heads, so that they can take a shower and minimize getting their catheter wet. So for people who responded that their patients do take showers, is your facility or organization doing anything similar? Or, you're just telling the patient to take the shower, without any additional precautions?
It's like a modified shower. They can wash their hair separately, sponge bath, face down to the level of the chest where the catheter is, and shower from abdomen down to their toes. So that's exactly my instructions to them.
Okay.
Well, actually, I used to work in an outpatient setting. We see some of those patients with wet dressings when they come to our unit. But now I work in an acute setting where we do chlorhexidine bath for patients with catheters. That's daily chlorhexidine bath to reduce clotting. But my question is that in one of your slides earlier, there was a higher percentage of healthcare professionals who responded that they wanted their patients to have a shower with precautions, which in my facility also, we don't have a standard. In my facility, we recommend them to have a sponge bath. Mm-hmm. But if they have to have a shower, they have to make sure they wrap it with saran wrap, plastic wrap, tape it, make sure that it's not wet. So in Canada, do you have a standard for patients to shower? Or do you just tell them, yes, you can shower? I mean, is there a precaution for them to make sure that their catheter is covered?
Yeah, so the answer to that would be that no, there is no standardized across the board recommendation regarding showering in Canada. There is one hospital or university, University of British Columbia, UBC, that actually does have a publicly provided shower protocol that's available online, where they actually do go through how to advise your patient to shower when they do choose to shower. So it kind of like a little asterisk at the bottom that's like, we still don't recommend that you shower, but if you're going to do it, this is how you should do it. So that was the only protocol that's available that I actually could find in Canada, institutional wise. I think that what we're hoping for, though, is that there could be something that is more standardized across the board. I think that right now, the general recommendation is similar to what the two of you gentlemen have said, is that, recommending a bit of a adjusted form of hygiene. But I do think that we need to move forward with a, protocolized way of addressing this, especially because patients are showering anyways. They're going above what we have recommended them to do, and they are having a full shower.
We had two questions.
So when I worked in the inpatient setting, they actually had shower Catheter, which looks like a giant Catheter with goes over your IV. So I had a couple of patients in the outpatient setting say they ordered them on Amazon and they just stick them over their central line when they take a shower and then they take it off because it's just the outer border that's sticky. It's not necessarily the inner piece. So it sits around it and then it peels off nicely and it doesn't
That's nice.
dressing on.
And it stays dry, like completely dry on the inside?
For the most part, I mean, we have I don't know if they all use them. Definitely people come in with wet dressings, but they fess up and usually say, yeah, I take a shower before I come in on dressing change day. That way it comes off right away anyway.
Interesting.
Okay, I had another question.
So for those sites that do seven-day dressing, that would be challenging. Every 7 days, they might use this device. Interesting.
Yes, I work in an outpatient facility, and we also encourage them not to shower, but like you said, the patients are going to do what they want to do. So I always have a caveat. If you're going to do it, just make sure you don't have water go directly on it. Do what you can, or when you come the next room, we're going to change it. And I think where the difference is when you have different dressing on the catheter itself. Because the technique, like you said, most patients are really creative. If the facility doesn't provide one, they get one off Amazon or Walmart or wherever they can find that can bring it to treatment. So that every treatment it gets changed. But if you have those that just go directly with the tip and the gauze, then the shower, it gets really dark, and that's where you begin to see those signs of infection, discharges and all this stuff. So I think the dressing also, if there's going to be like a way to recommend that, hey, we know these guys are going to do this, but the dressing they have on need, for example, we have those that get checked every week with the antibiotics on it, very, very useful. For those that have the regular cigarette that gets checked every treatment, even when they shower, pressure and cough, they know it's going to get changed, so you're kind of minimizing the risk of it getting infected.
Yeah, great point.
So Dr. Collins, one of the differences that you mentioned this morning to us is when you put in a catheter in Canada, the expectation is not to have it removed. Is that correct?
I learned about your 90-day policy today, and for us, it's when we have someone who starts on dialysis, I wouldn't say that there's a 90-day thing. It's more like specifically talking to crash dialysis. Once they have started on dialysis, they usually get a temporary line in hospital, and then we put in usually a tunneled IJ line, which I've learned you guys do only subclavians, but we put a tunneled IJ line in, and then the hope is that once the patient gets to their outpatient hemodialysis unit, that they now learn, if they hadn't already, they sit down with modality educators and they go over their options, and it's a bit more of a patient-centered approach, I think, with what their preferences are on whether or not they would want to proceed with having their catheter, or of course we would strongly recommend that they have fistula or graft, but if that's not within something that they desire, then we have a lot of patients who just stay with a central venous catheter for their duration of their dialysis time. So I wouldn't say that it's as strictly regulated that you guys get dinged, you said, at 90 days if you haven't removed the catheter.
We taught her that word, dinged.
Yeah, so that's super interesting.
Hi. So I actually have a very different perspective because I work in peds dialysis.
Peds dialysis?
Yeah. So they can't always get fistulas because they're so little.
Yeah.
And we don't follow an NPJ. I have kiddos who've had the same catheter for years.
Yeah.
And that pretty much works out okay, because when you look at the regulations or when you get a report back, it's basically looking at patients over the age of 18. Yeah.
We don't have any issues with it, obviously, because of that. But,
Right.
Yeah.
Well,
Yeah.
that's good to hear.
Yeah. I mean, we have patients that have been on dialysis for many years that have the same line. If anything, over time, that tunnel, it fibroses so well that I think it actually becomes safer with time. Unless, of course, there's an infection. But that tunnel, it gets very fibrosed to the cuff, and it becomes a very safe thing, I think, overall. But.
And we've had kind of the same thing with those tunnel caps, and you had that patient who's been doing dialysis for 11 years with the same catheter, but you notice the lumens coming from long, all of a sudden they get damaged, and also they get shorter, to the point where there's not enough lumen to replace or to repair when it gets damaged. And I do acute in-hospital dialysis, and we do a lot of temporaries at the very beginning, and there are IJs. Then we also do a tunnel IJ afterwards, because our outpatient centers will not accept a tunnel catheter. So they have to have, or if they won't accept
IJ,
temporary.
attempt.
Oh, gotcha.
Yeah, so it's one of those things, we move over that direction as well. And kind of like she was saying earlier, we have a special dressing in our hospital that we use, but our patients through throughput are now getting placed everywhere, not just on renal floors. So it's kind of more standard that a lot of our patients take showers, they use that big dressing, and we replace the dressing every 7 days or PRN when it gets soiled. So they get changed a lot of times well before the 7-day mark, and that's new issues too. But that's just kind of what we see in my facility. So.
Interesting. How big is the dressing? Like, does it go over the shoulder, or it just goes here? Okay, cool.
I've seen some though that go over the shoulder, like it's a plastic thing on one of those mail order sites, and it starts very low and the plastic goes over so that it covers, practically the entire body, and they need to wear that while they're showering, which it's my understanding that they pay for on their own.
And we've had patients who come back in who ask for extras to take home, so they have them because they'll even say that they use like their Walmart plastic bag. Tape up around.
Yep. Yeah.
So they can't shower, but we could put a Walmart plastic bag on them. In New Jersey, they don't give bags anymore. We have to bring our own cloth bags in. Otherwise, you have to carry all of your items out to the car.
Oh, wow.
So I don't know what the patients, and maybe that's in other states too. We just started it. I have a trunk full of those shopping bags that I have to bring so I don't forget. But, they've devised ways, some patients, to listen to us. And so are we giving them the correct information and supporting their needs for not only self-reliance, but to me, self-esteem, or just I don't know, is that the word, self-hygiene, or taking care of themselves? I don't know. It leads me to a question that we did not put in this poll. If you were a dialysis patient and you had a catheter, if you could raise your hand, if you would, no matter what your caregiver said to you, would you take a shower? Would you take a shower every day? Or just the days that you're going to, one patient said to me, I'm not showering on the day I come to the unit because you'll figure it out, and then we have to have that discussion. And then there are other patients who said, no, I'm going to shower when I come in, too bad on you because I know you're going to change it. And so would you shower every day? Raise your hands who would shower every day. Because Mother's Day's coming and it's Sunday and I wouldn't be going to there, so I would shower then. Would you just shower on dialysis days? Not as many. Most of us would shower every day if we had that choice.
Alice, you touched on something earlier too about the trust and the relationship between the patient and the caregiver. So we don't really want to, I think, admonish our patients for taking a shower, but we do because, you're looking at the metrics and things like that. So we want to look at ways too that you can build trust in that relationship so that the patients would be honest, about their activities when they're not at the center.
Right, because it's difficult to care for a patient if you've already established a level of distrust about how they live every other day. And then we say to them, or I know I did, tell me what you did, tell me the truth. I will always tell you the truth. And I'll do my best to tell the truth. Or, and to have that relationship, which is a long-term relationship of, a wink of what I'm doing versus, what I'm teaching them constantly. And so our next question, let's see if I can get that to go. You might have answered some of this already. Do you believe when questions, patients hide the fact that they shower? And that's like resounding. All right, so we have 87% said yes, that patients when questioned hide the fact. Oh, we're going up. People are rethinking here. Be honest. That's what we want. Okay, so 84% believe patients hide the fact, and 16% believe that they don't. And so one of the interesting, and we talked about this, and we could elaborate a little bit more with things, I kind of know which patients don't shower. I may not know exactly which day the patients who do shower, but you could definitely, as a nurse or as a caregiver, as a physician, meet patients and kind of think to yourself, okay, they probably have showered. And whether they do it appropriately, or are we giving them information so that they can do it within whatever safe guidelines we feel are correct. And there's really nothing out there that defines that.
Right.
It could be facility to facility. So Loretta, I hear you saying something you want to...
Oh, no, I'm good. I had the allergy thing, sorry.
So what's our thoughts about the patients hiding or not telling us that they do shower? Yet more than likely, we kind of know. It's not like your phosphate binder. When they don't take their phosphate binder, what do we see? The phosphorus goes up, or they're eating, potassium level foods and say, oh, I didn't do that. Really? Then how did your potassium get to be 8.4? I don't know. Or no, I don't drink anything. And we used to say, well, you weren't standing in a shower with your mouth open. And they'd say, well, I don't shower. And I'm like, well, there you got two dings, because I know both of those are wrong. So it's having that honest, open communication with the patient.
I think it brings up an interesting point, though. How many of you actually ask your patient if they shower? What was that?
I didn't hear what they said.
Another thing we talked about, when you're doing your BSI reviews and you're looking at your patients with BSIs, do you ever ask that patient, do they shower, as part of your review? You do? Okay.
That's our next question.
Oh, okay. Oh, jumped ahead, I apologize.
When reviewing infections related to patients with a CVC, do you ask if the patient is showering?
I have to say, personally, I don't think it's something I've ever actually asked a patient when they come in with an infection. So it's something that I will have to start asking. Yeah.
Yeah, but we already established that most don't tell us the truth. Because we don't want them to tell the truth. I think that in some ways we don't want them to tell us the truth. I'm showering, because they don't want to tell the truth because of our reaction coming back. So that was one of the discussions that we had when we were thinking about this session and proposed it, was how many in your QAPI, how many when you're doing an infection review when a patient goes to a hospital, patients on antibiotics, who has a catheter, were most of the time, I'm going to say, assuming it's because of the catheter itself, are we ever asking the patient if they shower? Is that part of your root cause analysis when you're talking about that patient?
I think a lot of times, though, they're in the mindset like, that's never going to happen to me, so they won't tell you the truth until it does happen to them, and then they're like, yeah, I did that.
Yeah, it's interesting. So I guess...
We have 45 minutes.
Yeah. So I guess the thing is I think after talking about all of this, does anyone not agree with the idea that we should probably have a protocol in place that, recognizes that it could have a theoretical increased risk of infection, but now we need to actually provide guidance on kind of the middle ground where we're balancing patients' quality of life and their risk of infection and giving them but if you are going to do it, this is what you should do. Does anyone disagree with that? So I think that's the next step, I guess, right? And yeah.
I'm kind of thinking about. So for this shower, is one of the discharge documentation. So every patient is the catheter. They are giving this discharge education, how to take out the catheter at home, and we show how on the video how to shower, and also give the on fire, and also upon discharge, right? patient can have the dressing set bring home. So let's say they are taught how to shower themselves, but if accidentally it's wet, they are expected to change themselves. So we're giving a simple set that teach how to wash hair, how to clean and cover it. So just to prevent any kind, let's say there's a wet dressing, let's say the dialysis days next day, so they can change themselves. Yeah, so this is our part of the education when we charge.
So in a sense, it sounds like you do have a shower protocol where you work. Yeah.
All the
Yeah.
they have the catheter inserted, so the nurses will teach how do you shower, how do you prepare yourself, and if there's accidentally wet, and then you follow this dressing to do the dressing for yourself. Cover it. Yeah.
Interesting.
Is this for home patients or outpatients?
Okay. Because hospital outpatient coming for the catheter insertion, upon discharge we just give. So they may go to the chronic dialysis center after discharge. Yeah. So they can outpatient, they can do it in the outpatient.
Can you summarize it maybe?
Yeah. So she's just saying that her center actually does provide education for patients who have had their central venous catheters just inserted, and that education does include guidance around showering. And then in addition to that, they also teach them how to change their own dressing if the dressing were to get wet, and they give them the needed materials and provide them with, what to look for, how to change it, and when to do it. So the patient kind of becomes more self-efficient in their dressing care, and then also allowing them to now shower as well. So essentially, you have a shower protocol, which is, I think, where we would like to all head, which is great. The group that I did the survey study with did publish another journal article prior to the survey study where they did something very similar, and they implemented a shower protocol just like that, where they taught patients how to do that. The idea was to try to assess for whether or not the stream of patients that showered using that protocol had any increased risk of infection compared to those who didn't. But the study size wasn't large enough to detect like a statistical significance. So there wasn't an increased risk of infection, but you can't definitively say that. So there is kind of the next best thing of giving proper evidence for that, which is supposed to help, provide us with, further understanding of how to proceed. But what you've talked about is, I think, the goal of everything would be to have some form of protocol out there for patients who are willing and capable of doing these types of things, which isn't all of our patients, but for those who can and want to, that we're giving them the way to do it. Yeah.
Well, and I was wondering, with some of the things, I just recently had a mock internal core survey, and some of the big things that we're looking at with all of our catheters, not just hemodialysis catheters, but just central lines, were like the securement devices. So my regular people were really curious because they know a lot of our hemodialysis catheters, the sutures have finally kind of eroded through, they're gone. And so they were questioning me, how are we going to answer, what are we going to do if they notice this, if they call us out? And I addressed it at that time. But what are your thoughts on that? We also had some talk about using a secure port, like a glue, on the insertion side to help with that, and also to help with central lines. So what do y'all think about all that kind of stuff? Because I would worry that the patient thinks, oh, this has been glued here, it's now basically water resistant. I'm more likely to want to go and take a bath, not just a shower, or get in that hot tub, or,
Yeah, I mean, I think the idea of the glue sounds great, because I do think that, I know that at least over time, that tunneled line, that tunnel, it is so nicely fibrosed, it's almost impossible to pull out when you need to. But there is that little part at the skin where it is coming out that kind of wiggles around a little bit, gets the redness, makes you feel uncomfortable. So if there was a way to kind of, close that with some kind of glue, perhaps that would be the good way forward. And then I think we would have to just strongly recommend that they do not fully immerse themselves in water. I think that should be a clear thing that we should avoid, especially hot tubs and lakes and stuff like that. But
I would say that I would probably feel safer with them having a little extra securement device with them showering. Like, yeah.
My fear is how long will that really last? So it's supposed to last for X number of days. Does it really help when you have to reapply it? And reapply it?
Yeah.
Tracking things you shouldn't. Do really good cleaning around it at that point in time. And then the other big thing, of course, in all the new surveys is what is the manufacturer's instructions for use? So what do the catheter companies say?
Yeah. Yeah. Well, I don't know about this glue thing, but these are the questions that I would definitely be asking. And because does it just increase the risk of infection at that point? So I would have to look into that and see what kind of information they have available, what studies they've done to make it into something that I would want to use or not. Theoretically, it sounds great, but yeah, practically, to be determined. Yeah.
But there's other options out there that maybe we need as a community, a nephrology community, to really investigate so we could give our patients a better quality of life. And that's what we had hoped from this session, that we bring to light and, share that information of maybe we're lagging behind other countries, the rest of the world, but maybe we're doing a disservice to our patients by saying to them, do not shower. And again, I'm going to harp a little bit on that, building distrust on the patients, which is not what we want to do. We want them to trust our profession and our community.
Yeah. I think the goal overall is always going to be patient-centered care, and I think there's always going to be a balance. And I think as long as that we've spoken to the patients about the potential risks associated with the decision that they make for themselves, and we've done the best to educate them as best as possible, then I think that it's a shared decision, and we should be able to do better with giving them guidance on making that shared decision.
As we were writing these questions, we thought as we were giving this discussion or having this discussion with you all, that other questions would pop up, and one just came to my mind. Do you think it's dependent on whether or not the PCTs in your unit are allowed to change the dressing, whether or not you feel comfortable to tell the patient they could change the dressing at home or take a shower? If you think, your organization, do you think that impacts the discussion we have with the patient? Yes? Because if I can't allow the technicians in my unit to change a catheter dressing, then how comfortable am I going to feel with allowing the patient to take a shower and potentially cleansing their own dressing at home? I see someone nodding their head like, yeah, are we being too protective? And is that necessary? I don't have that information. I'm just throwing out that question there.
Yeah, because it probably depends on per facility and state to state. Because there are states that doesn't allow PCTs to take care of patients with CVC.
It can only be nurses in Georgia.
Even to do the dressing change? In your unit, in your area, do you allow patients to shower then? Do you allow patients to shower?
They encourage not to, yes. I'm the dietitian.
No, you would know. Listen,
this is very interesting, but yeah, they do not encourage showering.
So in some states have their own regulations. So it varies across the country on whether or not a patient care technician who works within the unit can change the dressing or even access the catheter.
I don't even know what a patient care technician is.
Someone here like to explain? Do we have PCTs? Danny. Just because I know his name and he raised his hand. Go ahead.
Has there been a study that has been done to actually verify that states that allow technicians to do catheter has more infection rate than states that do not? Because if we can do invasive procedures, aseptic procedures, and stick that 15-gauge needle deep into a vessel that a nurse can't sometimes cannulate, why are we not trusted in our confidence and ability to do catheters?
So Dr. Collins isn't familiar with the role of the PCT.
Yeah, I don't actually, we don't have those in Canada, so.
We're certified technicians in the country that's required by CMS to perform the analysis from initiation to discontinuation. that includes piloting the machine, cannulating the patient, taking them off, monitoring them, adjusting parameters during dialysis when there's issues or problems with the patient. Technically, we provide the greatest volume of hands-on care to our dialysis patients.
So what is the difference between a dialysis nurse and your role?
They're not allowed to do, they cannot do assessments, provide medications, except for in some states they could actually give the heparin. In some states they can't bolus saline, maybe 100 boluses times 3, and then they have to pass that on.
We became dominant caregivers when we commercialized dialysis.
Okay.
And there's the national certification exam that's given by multiple agencies that they must pass within 18 months of work. Otherwise, they cannot work 18 months in one day, right?
One of the functions in my history, I've been in dialysis over 50 years. It was that I did education for new staff, including nurses. And I would show them and tell them how to care for catheters, but I couldn't touch it.
So, sorry.
We just opened a whole nother discussion.
Oh, yeah.
Right.
Okay, because like in our unit, the techs.
It's state specific.
Yeah,
Yes.
so they can do all that. They just, on certain days, we change like the dressing and the Tegos that screw onto the line, and the nurses have to do that with the techs.
They do everything in Michigan.
They don't have that in Michigan?
No, they techs do everything except give meds. Everything.
Yeah, we do everything.
I want to know.
He's looking for a raise, I could tell.
In Texas, we just actually got a law passed to allow technicians to start accessing the cartridges, but they cannot change the dressing.
But they cannot change the dressing.
The nurses have to do that, then pass it over for the tech to access catheters. They can give heparin, no.
So you can give heparin, you can access the catheter, but you cannot change the dressing.
That might be because the change in the dressing is actually an assessment, has an assessment piece, is the only thing I can think of.
You could change the dressing and the nurse could come over and look.
Yeah, and look at the site and document, that's true.
I think I'm going to need to buy her a drink after.
I think you had a question?
Oh, I just had a comment. So our techs can access catheters and also change dressings. But when we've done audits, we've seen that a higher infection rate when the techs change the dressing versus the nurses. And I think it has to do with sterile technique, because we do sterile dressing change, which nurses learn in nursing school and techs learn on the job. So just a thought. I'm not slamming techs.
We'll protect you. We'll protect you as you're leaving.
But we have noticed that there's more breaks in technique for the techs than the nurses.
Yeah, okay, so they're allowed. And private home patients are allowed to change their dressing, or we just talked that some patients can change their dressing if they take a shower, and we could teach them how, yet you're seeing a rise in infections for whatever, because I don't have all the details. But, and it's not a sterile technique. I would be.
Breaks in sterile technique for techs are a lot more common than breaks in sterile technique for the nurses.
But is the dressing change in your area? Again, this is actually, kind of going off, but good conversation. It's as far as I knew, it was it's not a sterile technique to change the dressing.
At my facility, it is a sterile technique.
So it's the differences, yeah. Okay.
Interesting.
There's a job security thing going on back here.
Yes.
Hans, I think in your presentation, you said there's no study to find out if a patient with a CVC taking a shower increase the rate of catheter infection or bloodstream infection, right?
Correct. There's no randomized control trial that's ever been done.
Can you comment why, and can we do one?
So that would be the dream, would be able to do one, but the rates of catheter infections are already so low that to be able to find a statistically relevant difference in two sets of people in a thing that exists already at such a small rate, it would have to be such a large study to be powered to find that difference. That so many people would have to be enrolled, and then there's also the ethical considerations of randomizing something like that, where the assumption is that the rates of infection will be so high in the one arm, theoretically, that getting actual approval to do a study that large to answer that question is likely not feasible, which is the whole point behind the survey study that we ended up doing, was to help inform, what type of next step might be needed. And if we were to do some kind of study, what type of study would be ideal? And then also just figuring out what type of questions we might need to answer in said study. But it'll never be a randomized controlled trial that's going to give us the answers that we want, unfortunately. Yeah.
Second question, what is the locking solution you use for the catheter?
In Canada, at our institution, we use citrate.
In my institution, we just do heparin, 1,000 units.
So we use citrate, but after the hurricane a couple of years ago, there was a citrate shortage, and we had to switch to heparin. And we did actually notice an increase in infections when we were locking with heparin.
Interesting.
Mm-hmm. We use heparin also.
But we did notice more infections for those that were locked with heparin versus.
Interesting.
We have another question.
You started using this new medication. We use medication with heparin, called Standa, and we haven't had BSIs for a while when we started. It's like it has chlorine on it. So
It's flexible.
It's called the Standa. We lock our.
What is it?
It's like heparin and chlorine, some kind of antibiotic, like prophylaxis to lock it.
Antimicrobial lock solution is what it is.
Okay.
Yeah, and we also use the citrates, and my hospital system is trying to get gentamicin and citrate locks. But we have the same thing with a shortage. Where I can't even get citrates, but we got citrates up north where they can get it, so.
Yeah.
So.
Interesting.
But I think to your question as to why there's not a study, I think it needs to start in your unit for a patient who has an infection, and add that to one of the questions that are asked. Does this patient actually take a shower? Because, when was the last time the patient took a shower from the date that the infection occurred? Because that way we would have some data to prove or disprove the use of showering in patients with catheters. And maybe, I don't know, we'll follow our friends in Canada and not necessarily have to worry so much. Just a suggestion, and KF is not supportive, this is whatever. I always want to be mindful of that. Maybe patients don't necessarily have to have those catheters out in 90 days. It would be more of a choice. It's just a thought, just a suggestion, just an idea, because we're not tracking those.
And also, one of the recommendations I give my patients, if you have to shower the day you're coming to dialysis, so that we can change. We don't need to shower and leave it overnight. So there's some compromise you come to with the patient.
Yeah.
Hey, we're all looking out for your safety. So if you have to do it the day you come so that we can change it immediately.
So I have a question for Dr. Collins that just came to mind. Why do we put dressings on a patient if they can't get wet, you can't sweat underneath the dressing, if it's completely tunneled? And we're cleansing the skin. We're cleansing the skin, not the, and this is something, we're cleansing the skin. I put you on the spot here.
Yeah.
Cleansing the skin, not a little bit of the exit site. Then why are we doing that? And again, that's another
I think
broad.
it's protecting from, like, there's so many, like everywhere you go, there's going to be different flora, everything like that, right? Like, I think you're limiting the exposure to whatever microbiome is out there. Even, like, you know, we might wear a scratchy shirt, right? And the shirt might pull on that little tiny nub that sometimes is on the exit site, and then that might open it up, and then the exit site might get infected. I definitely think that dressings are important in protecting the integrity of the area, even if it was, just to protect the skin barrier itself, to make sure that it's staying in sight,
Some of those dressings are so large, it's like half the person's, you know, they don't come in graduated sizes for a small person or whatever, that, you know, we're cleansing a lot there.
I think it's a low, like, non-invasive, you know, not too costly thing that we can do that possibly has a significant benefit. I think the cost benefit there is likely to lean toward continuing to do those types of things. Yeah.
Just curious.
Yeah.
Because we talk about who changes the dressing, whether it's sterile, whether it's not, what we're using to cleanse it with. If you're using a chlorhexidine patch, you're not using that. If you're using alcohol or betadine or what you're using to cleanse, how we're teaching a patient, if we allow a patient to change that dressing if they do shower, quick, put that dressing back on. So we are dressing focused.
Yeah, for sure. Yeah. Do you have another question? Sorry.
Going back just a little bit to where Alice, where you said we need to start in our units. So, Dr. Collins, we saw your study a year ago, and so we implemented a showering protocol and did a bunch of patient education, right? So we had written materials about what the showering protocol was, which was really just, you know, make sure your dressing is intact and cover it. We provided the covering materials. We used shower shields or lab press and seal. And we were really looking at patient satisfaction, but we also wanted to see what did it do to our infection rates. And of course, patient satisfaction went way up. Patients loved being able to shower and feeling like they were allowed to. And we didn't notice any increase in our class rates. So again, like super small, right? We have 60 patients over 4 centers that were included in this, that were provided with the education and the materials to shower more safely, and no increase in infections. So
that's awesome. I mean, you should publish that.
Well, she has a poster.
Okay.
So, do you remember where your poster's located? What?
It's 393.
393 in the poster sessions, please.
Yeah.
As a poster that they did and a study that they did in their institution.
We loved your whole study and article.
Oh, well, thank you very much. That's awesome.
So, real world, like, our protocol was great. The patients loved it, and really we were looking at the education and the patient satisfaction, and it was through the roof. Right?
That's so good.
Patients cried happy tears.
Oh.
They were so glad to be able to do something that had been taken away.
That's awesome. Thank you so much for sharing that. That's so exciting, and I think that, you know, that information and any other like opportunities that come from the units themselves are going to allow us with enough almost like observational data where we can kind of, it's not going to ever be an RCT that's going to inform, you know, evidence that's going to provide the actual protocol that can be maybe universal, but it's going to be expert opinion about all of these experiences and the experience that you guys have had and that you're sharing, that we can maybe come together and create some kind of expert opinion protocol that allows people to shower and everyone feel that way. So that's awesome. So thank you.
It would be great at some time if there was a, maybe NKF or another association would create, you know, a walkthrough video of how a patient can, how to shower, not how to shower from, you know, how to shower with a catheter, so that we all come with the same data. Again, what we've just identified here is most of us are not collecting that data on our patients, whether or not they shower. And I don't believe from what we're hearing that it's uniform, the information that we're actually presenting. Some of it's really excellent, kudos. but it's not uniform across the board on how we address the need for the patient to maintain their own hygiene, self-esteem, while they're on dialysis with a catheter, and maybe the time has come for that.
Yeah, absolutely.
Yeah. We do have some more time left. I guess we talk fast, or at least I do. Any other thoughts? I think this is something that's timely and that we need to come together as a community so that we're giving the patients the same information. And also, you know, our patients are starting to travel a little bit more, even within the United States. And when they go to another facility, and this happened to me, in my other facility across town or where I used to live, did not allow that at all, and my nurse made sure, and I trusted my nurse, and now you're telling me that I can or cannot shower in direct opposition. And it made for a very uncomfortable patient coming to the unit who we were attempting to acclimate to a new environment, a new nephrologist, new nurses, a different chair. And so it made it really challenging for that patient. They were uncomfortable for a significant amount of time. They were calling their own unit about something simple, about a shower. And so I think, you know, this has just made us recognize that we need some standardization, or maybe collaboration is the better word at this point. Any thoughts, additional thoughts?
I know, Doctor, you said about you're not pushing for the removal of the catheter right away, right, after 90 days. But here in the U.S., we're pushing for fistula first. We have fistula first initiative. How does that affect your adequacy of dialysis and your symptoms?
That is an interesting question.
Because here, I mean, CMS looks at the adequacy of dialysis and the dialysis centers.
I will say, like, we also want to be fistula first. Like, we want to, you know, if a patient can have a fistula or a graft, like, that is goal number one, especially when we have time, like, in leading up to them being on dialysis, to preemptively organize for that. I think it becomes a little bit harder and probably a little bit more gray for us once they've already crash-started dialysis and they already have a line in place. Getting the patient to then get onto a fistula can be a little bit probably more cumbersome than it is maybe for you guys, from what I hear. Patients get very comfortable with where they're at, and sometimes they don't want to change, but it is still something that we would want to do. The more peripheral, the better, the longer they will have dialysis for. With respect to the efficiency of the dialysis, I would have to look into, like, the data. I wouldn't be able to really comment on how the efficiency of dialysis would change between Canada and the States. I haven't seen anything that I would be able to say would be quite different. I don't have any issues with the patients that are on dialysis for many years through their central line. If they do, then we can fix it. But if anything, sometimes I feel like the fistulas have more issues with everything, like, you know, with recirculation and everything like that. If anything, the patients that have lines when you're in the dialysis unit are kind of the more simpler ones. But, I mean, that's just my experience, but yeah.
But in my experience, a poorly functioning catheter is a poorly functioning catheter that we're going to have problems with adequacy. A fully functioning catheter is not going to affect the adequacy of the patient. And so it's not the catheter itself, it's how well it works. Same thing with a fistula. If you have a fistula that you're only able to get 200 blood flows, you can't increase the patient's time to 5 hours, they're not going to meet adequacy, you need to change it. Again, with a catheter that's not functioning, it's not good. But if you have a functioning catheter and you get 350, 400 blood flows, you should be able to meet adequacy. And so I don't know, I'd have to delve into it a little bit more, why that would impact longevity of a catheter. Because we can't say across the board that a catheter that's in an extended, what we call extended, past 90 days, is an ineffective access to provide dialysis for every single patient.
Yeah, because I think the problem also is that CMS looks at the center based on how many the percentage of your patients with fistula versus catheters. They would want to see more fistulas than catheters. That's why there's really a push for that. Supposedly because of the evidence.
I'm sorry, what
I think a problem is when metrics are not based on patient preferences,
Yeah.
right?
when our care is based on metrics, not
Your
patient.
quality metric is based on, the percentage of catheter use. If patients don't want that or need it, we need evidence-based to make that metric in place. For sure, fistula first, lower infection rate as a whole, absolutely. But there's lots of situations where it doesn't, the fistula doesn't mature or,
Yeah.
Good point.
And for the access, I think that's the reason why that CMS has not mandated that has to be 100%. So, you have, like, I think it's 15% or 10% maybe. So you have this 10% of your patients that would not fit the criteria because they're CBC dependent, because, some patients wouldn't want CBCs, wouldn't want a vascular access. So, that's probably the reason why it's not 100%, because some patients fall in 10% outlier.
Interesting.
Dr. Collins, what is your catheter rate? Like how, we're talking like 10% of our population is okay to have catheters. So what's the percentage of patients that have catheters in Canada?
I think it's around 60 to 70%, if I remember correctly. I believe.
Okay.
Yeah. And then in our center, I think it's similar, but I'm not 100% sure.
And your CLABSI rates are low?
Oh yeah. Yep. We meet all the guidelines. Yeah.
And I also would imagine if a state or facility would mandate that only nurses would take care of CBCs. Imagine, if you have 60% of your patients are CBCs, how many nurses would you need versus?
You're all nurses.
Well, we only have nurses that provide dialysis.
Right. I'm saying here in the States. So, in terms of manpower cost for dialysis providers, if they only mandate nurses to take care of CBCs, and if your CBC patients with CBCs are 60% of your population, so that would require a lot of nurses.
Yeah.
Well, one of the big differences, it sounds like, between the U.S. and Canada is in Canada, healthcare is provided for everyone, whereas here it is not. And a big majority of our patients on dialysis are pretty much being paid for by the government, which I think calls a lot of attention to the cost that are related to the care. But that's just my opinion.
Yeah.
Well, do we think that cost drives whether or not a patient can shower? Is there a dotted line to that?
To me, I think there's an indirect cost to say if it increases the risk of bacteremia, then it increases the cost of the care for that particular patient.
But we don't know.
No,
We
exactly.
don't know if it increases the risk of bacteremia. And I'm just saying, on this very small study that we just did in this room, that
Who pays for antibiotics for a patient with a central line catheter infection? Who pays for the hospital stay? Is it the patient, or does that come out of dialysis funding here?
Yeah, it's from the CMS.
The patient themselves, like the funding profile here covers all care for a dialysis patient?
yes, it's a bundled. We have a bundled payment.
Antibiotics, medication.
Okay, well that's good.
Sort of, because if they come into the hospital at that time, then the government doesn't pay for it. Then the hospital pays for it.
Yeah.
Right.
But you get you bill for it,
As long as they haven't had enough admissions.
right? Depending on how many admissions, it's not.
You have so many times they can come in and they'll reimburse when they do not, and the hospital eats the cost.
But for the dialysis patient, for the dialysis facility, the provider, if it's related to dialysis in any way and any sepsis with a catheter is assumed to be a catheter-related issue, then the facility pays for the antibiotic.
Okay.
You know, our BSI is going to a national database to
Okay.
monitor infections.
Say
Okay.
that? I'm sorry, we didn't hear.
I said, and all of our BSI is going to a national database to monitor infections. I don't know if Canada does it. I was just letting her know that's what we do.
But it'd be interesting if they added a line item that said that the patient shower.
Yeah.
All right. Any other questions or thoughts? Because this was like a small study here. You know, we need to expand upon that. You know, your research and article, the poster presentation at, what was that number again? I'm sorry. 393. I hope to see you all there. Let's just converge on this and read that. And just to bring some of these thoughts home so that we're collecting the right data, so that we're making the right decision that's best for our patient, and maybe some consistency across the board would be probably beneficial for everyone. Anyway, we're going to give you back some time. Appreciate it. Thank you for joining. And I highly recommend everyone, if you're not already a member of NKF, to join as a member. Then you could come back next year, and members receive discounted rates to the symposium. And hopefully you'll be at another one of our sessions, which would be great. And don't forget that by June 22nd, you have to do your pre and post test in order to get your continuing education credits. Otherwise, you went for the fun of it, which is just good too, but it's also nice to have your continuing education credits. So I thank you all. I look forward to seeing everyone out there. And I thank our panel presenters. And Dr. Collins, thank you.
Thank you.
I learned so much from you about what happens. Thank you all.